So let's go ahead and get started. Today is Wednesday, January the 12th, and welcome to the Society of Thoracic Surgeons General Thoracic Surgery Database monthly webinar for January. Happy New Year to everyone. I hope you are all staying well and staying safe. Let's go ahead. Let's move on to our agenda today. I just have some brief STS updates, and then I'll turn things over to Ruth, our GTSD consultant for our education. Then we'll finish up with IQVIA, and then again, as usual, we'll have our opportunity for your questions at the end. Please submit your questions via the Q&A. If you'd like, the raise hand function is also enabled, so just raise your hand if you'd like to speak or clarify your question if needed. Just make sure you are unmuted on your end. Enable your microphone so we can hear you. On the call with me today from STS, we have myself, we have Carol Crone, we have Emily Conrad. Let's see, who else do we have here from STS? From our core group side, we have Katie and Ruth. Let's see, from our IQVIA team, we have Jean, Joe, Melanie, Michelle, and Steve. So thank you everyone for joining today. Let's go ahead and hop into our STS updates. The January training manual is coming soon. If you're waiting on an FAQ response, we do have our core group call scheduled for tomorrow. So we will be covering and tackling the rest of our questions, and Ruth will be getting back to you shortly if you are awaiting a response. So once that call is finalized tomorrow, Ruth will get those training manual updates over to me, and we'll get that posted ASAP for you guys. So sorry about that. Things got a little wonky because of the holidays, so we're getting back on schedule. The fall 2021 harvest update, just to let you on, the analysis data set was received from DCRI. And that risk adjusted report will be available to you all in the coming weeks. IQVIA is working hard to get that data into the platform and ready for you all. And also just a reminder that the new pulmonary resection composite was implemented into this 2021 analysis. So that will be coming to you all here in the coming weeks when this data is released into the platform. I also just wanted to give a reminder that in regards to the COVID update, an official STS communication was sent to the entire STS database community, all database participants, all databases. Again, that communication was sent on December the 28th of 2021. And that in that communication, just reemphasizing that any COVID positive patient will continue to be excluded from current analysis, from 2021 analysis and the spring 2020-22 analysis. That impacts about 2.61% of all cases in the general thoracic surgery database, so a very small impact on the overall number of cases in the thoracic database. Analysis exclusions will cease for any record that has a surgery date of January 1, 2022 forward. So again, records with OR dates of January 1, 2022, if they are COVID positive, they will no longer be excluded. They will be included in the analysis. And again, we would like for you all to continue to collect those COVID variables until further notice from STS. Next, again, just a reminder that the spring 2022 harvest is currently ongoing. The harvest is scheduled to close on March the 4th of 2022. Our opt-out date is March the 8th. That will include procedures up through 12/31/2021. And then the fall 2022 harvest is scheduled to close September the 9th with an opt-out date on September 13th. And of course, that fall 2022 report will include procedures up through 6/30 of 2022. And this harvest schedule is posted out on the STS website under the STS National Database page, Harvest Instructions and Information link. So if you have any questions or have any issues locating that, feel free to email me and I can point you in the right direction. That's all I have from the STS perspective in terms of updates. Next, I'm going to turn things over to Ruth Rowley, our GTSD consultant, core group member, and and Ruth is out of St. Joseph Mercy Hospital in Michigan. So Ruth, I'll let you take it away.
Thanks, Leanne. So we're going to start off with just some education. This first one is something that I've gotten a lot of questions about recently. went back to the core group and to the surgeons to make sure that everyone was on the same page, because this is a pretty significant change from what's in the training manual currently, although it aligns with previous versions of the GTSD. So currently in the training manual for sequence 1560, it indicates to include hiatal hernias and diaphragmatic hernias, including congenital and acquired diaphragmatic hernias. That was not an intentional change. So the training manual will be updated to indicate to code yes to sequence 1560, which is this hiatal hernia, diaphragmatic hernia GERD, yes or no question. Only for paraesophageal hernias, not for diaphragmatic hernias. That means that section J will no longer open if the case that you are, or should not open for diaphragmatic hernia repairs. You will not collect that information. Of course, you're still welcome to collect diaphragmatic hernia repairs if you are entering all cases, but you are not required to.
And also just wanted to add there, Ruth, I'm going to get the data collection form updated. Carol and I had talked about this, so I'll get the data collection form updated and get that posted out on the STS website so that doesn't cause any further confusion as well.
Thanks.
Mm-hmm.
This was an FAQ that was submitted. So for pathological M staging, which is sequence 2060, if a patient has oligometastatic disease, which is commonly to the brain or adrenal glands, a curative lung resection is often still performed. The surgeon is going to generally note the plan for treatment of the metastasis in their preoperative note. In these cases, the pathological M stage is not going to come from your pathology report, but rather your surgeon or oncologist note. It's not possible for the surgeons generally to resect the brain lesion or adrenal lesion at the same time as the lung resection. So you're not going to see it on the pathology report, but it truly is part of your pathological M staging. Sequence 4030, which is regarding surgical site infections. I've gotten a couple of questions recently about whether or not a chest tube incision that is infected would count as a yes for sequence 4030, and indeed it would. It would be considered a secondary incision for a lung resection or esophagectomy for that matter. And if it's infected, it does get captured if the clinical criteria are met. Sequence 870 ECOG, provider documented Zubrod or Karnofsky performance scale scores can be crosswalked to ECOG and coded for sequence 870. Your site has to keep a record of the crosswalk that's used for entry, and it must be used for all cases. So the same crosswalk for every case. So this was just an example that I found of Karnofsky being crosswalked to ECOG. Another question about ECOG, it seems that at some sites in EPIC, there's a cancer staging tab, which includes clinical and pathological sections. The ECOG score is documented in the pathologic section. The sites were wanting to know whether that ECOG score can be used for abstraction and coding. And the answer, the core group talked about that question and determined that in order to use that ECOG score from that location, you would have to know who entered it and when it was entered. A post-operatively assigned ECOG score cannot be coded in this sequence. Sequence 2360 and 2370, which applies to anastomotic methods and conduits for esophagectomies. If a bipolar exclusion is performed, which is pictured to the right, it's literally just a dead ending of the esophagus. You're going to need to leave 2360 and 2370 blank because there is no anastomosis or conduit. That will be taken into account and addressed for the next version so that those cases can be coded more completely for 2360 and 2370. There was a question about sequence 1800, which is clinical staging lung cancer tumor size. So the Fleischner guidelines are a common radiology guideline for reading CT images of lung nodules and masses. Those guidelines direct radiologists to provide a mean or average nodule size for nodules that are less than 10 millimeters, in addition to a largest and smallest size. However, most of the nodules or like tumors that are resected by surgeons are greater than 10 millimeters. So in order to be consistent, always report the largest size of a nodule that's given in a radiology report for sequence 1800. Do not use the mean or average measurement for this sequence. And then we have a few polling questions this time around. Thank you to Melissa Clark, one of the core group members, for putting these together. So you should be able to answer these. It should pop up on your screen. A patient with a history of a prior transapical TAVR is now undergoing a lobectomy for lung cancer. Is this considered prior surgery in the planned operative field? Yes, no, or I have no clue are your choices. Hopefully you can see the poll.
Yeah, it looks like people are responding.
Okay, perfect.
Yeah, I think Carol's kicking these off. Is that correct, Carol? Are you kicking off the polling questions, or did I do it and not even know it?
Oh, I did it.
Okay, good. Thank you. I was like, did I start that?
I can't see the answers coming across, so feel free to reveal the response when you see it. Most have answered.
Okay.
You might be able to see it if you answer it, Ruth. I think
Oh,
you can
okay.
answer it.
Let me see.
Okay. Can you see it?
No.
Oh, I guess I'm the only one.
You're the only one who knows, Carol.
I can see it too, Carol. I'm going to go. It looks like the numbers will stop. So
Okay.
here's the answer.
So the answer is no. The thoracic cavity is subdivided. Oh, there we go. Now everybody can see the answers. So the thoracic cavity is subdivided into smaller sections. And so the TAVR would be considered pericardial, while the lung resection would be considered in the pleural cavity. So they are not considered to be in the same operative field.
Great. And do you want to go over the definition of what we mean by operative field? I think you did, but maybe because we have about 20% of folks who are having difficulty with this one, a little over actually.
Sure.
So really go into that. I think it would be helpful.
Sure. So I think that the diagram actually does a great job of sort of pictorially representing what operative cavity the surgeons are in when they do a resection. And so if they're in the sort of same color-coded space, you would code yes. And if they're in a different color-coded space, you're going to say no. And sometimes a procedure is done that is in multiple operative fields. And if any of them overlap with a prior surgery, you can code yes. It doesn't have to be the same exact procedure. This happens commonly with hernia repairs and esophagectomy, where there's some overlap, but not complete overlap. And you can say yes in those cases, but unless they're in the same color-coded section, you would say no.
That's really helpful. Thanks, Ruth.
Yep, thank you. Okay, the next one. During clinical staging for lung cancer, a patient undergoes a CT-guided needle biopsy of the left lower lobe tumor. How should interventional radiology needle biopsy be coded? Yes, this is considered an interventional radiology needle biopsy, or no, this is a core needle biopsy. Core needle biopsies are not captured in the database for version 521, or I have no clue.
Smiley face.
Smiley face, yes.
Smiley face. There's no problem saying I have no clue. That's what we're here for.
Yeah, and I think the whole point of the polling questions was great, is that there was feedback from a previous meeting that was not at, I think it was at our Michigan collaborative, and there was a lot of confusion on these questions. So I think that's, Ruth had a great idea to bring this to the national level and to provide education on it, because it seems that we all could use it. So thanks, Ruth. That's a great idea.
Yeah, especially on this question, it looks like if you're, like you said, in the Michigan thing, you were split like kind of halfway, and that's looking like where we are now with this one. So
yeah, here are the results.
Okay, so this one is a pretty big change from the previous version, and I think that's part of why it's so confusing. So the correct answer is no. For this version, core needle biopsies of the lung mass itself are not captured anywhere on the form. So you would not collect this information anywhere. It is an option under 1630 that can be selected only if there is a core needle biopsy of a lymph node performed, which frankly is extremely rare in my experience.
So if these procedures, if this CT guided core needle biopsy is performed, what do the sites just not collect anything?
Yep, you just don't collect anything. It's
Okay.
good information that we don't collect anymore. And I don't know the rationale behind why we don't collect it anymore. I'm guessing that it wasn't useful. And I know that we try very hard to collect data that's useful for projects moving forward, not just because we have historically.
Right. Okay. Thank you.
Mhm. Okay, the next one, pathology reports that within the left upper lobe specimen, 7 parabronchial nodes were found and are negative. Parabronchial nodes should be captured under which station? Station 4, station 7, station 11, station 12, or no clue. And I would say that if you have no clue, you can always ask your pathologist or surgeon and they'll always tell you. So it's a fair response in a quiz.
If only that would have been true in most quizzes during my school. No clue.
And Ruth, I have to ask, in the training manual, are the types of nodes listed underneath, or are they listed for the stations in the training manual, or is that something that we also need to provide? Maybe more?
I would say that I'm trying to remember it off the top of my head. Katie might know off the top of her head. I think we list some of them, but not all of them, maybe.
Sorry about that, guys. Yeah, I was trying to pull it up.
The picture on this slide comes from the training manual, but that doesn't. I think we use mostly station numbers in the training manual. I don't see, I'm looking what people are answering. I don't see that we have the crosswalking of the of all of the nodal station names to the station numbers.
Mhm. Okay.
So we can update that.
Okay, I'm gonna end the poll and share the results. There you go.
So parabronchial lymph nodes are considered station 12. And we can definitely update the training manual to include the common station names with the numbers.
Okay. And I just want to see something quickly on the DCF. I remember talking about it during the upgrade, but it may be that the information didn't make it over.
Oh, I remember, Carol. Yep.
Yeah, because we call them lobar for 12 on the DCF, but maybe we should also add the wording peribronchial since we have to make that other update.
Yep.
If that would be helpful for sites.
Yeah, there's sometimes more than one common sort of word that describes a number, I guess,
Okay.
is the best way to think about it. So yeah, we can update that.
Okay, thank you.
All right, our last question.
Following an esophagectomy, a patient returns to the operating room due to a suspected anastomotic leak. An EGD is performed, the leak is confirmed, and a stent is placed. How would you capture 3670, which is the question, did the patient have another operation through a new or existing incision? Yes, no, or not sure. Help me better understand. I think that's a winky face, Carol. You mixed it up.
Making sure you're paying attention, Ruth.
And again, I think 3670 changed pretty significantly from the last data version. So there's been some confusion on this one as well, just because of the change.
Yep. That's We're about split half and half here. Da, 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 da.
People are really thinking about this one.
Yeah. Looks like we're slowing down. Every time I say that, the numbers go up just a little bit.
That's
Okay,
right.
here we go.
come. Yeah.
Okay, so we're almost exactly split.
Yeah.
So the answer to this one is no. The way that 3670 is currently structured is that the patient both has to go back to the OR and also has to have a new incision or existing incision reopened. When an EGD is performed, there is no incision. It's essentially just a scope. Where you would capture this element is pictured on the slide. So sequence 3920, you'll capture the esophagogastric leak from the anastomosis. You would say yes there, and then it would be considered a type 2 for your grade. It required an intervention, but not surgery, again, meaning there was no incision required.
And I think that's all that we have. Those were great questions. Thank you for bringing those over from the Michigan group, and thanks to Melissa for providing that. That's extremely helpful. I'm glad we were able to cover that today.
Yeah, thanks, Melissa.
All right. Next, we're going to turn things over to our IQVIA team for our IQVIA update. Joe, you're up.
All right, great. Thank you, Leanne. Good afternoon, everybody. It's just some information regarding fixes that went through last month. These would have been done before the holidays. So starting with STS 7157 and STS 7239, we had received reports that the critical errors on the form for direct data entry users were a bit cumbersome and were disrupting their workflow. So we did work with the STS to address those concerns and improve the form validations on the whole. In regard to the risk-adjusted dashboard report, STS 6817, the missing data summary in the risk-adjusted dashboard was displaying hold on, let's double check. Yes, so that was displaying the missing force expiratory volume test performed as missing when it was not. So we did update the report's logic to correct that. And then STS 6921, in the number of mortalities section, we got a report that the total number said one thing, but the case drill down did not include the same number of cases. And so we did figure out what was causing that and fix that in a release last month. Next slide. And then some fixes for the missing variable report, STS 6967. The report had been showing the mort date variable as missing, even for patients who had not expired. So we did update the report so that the mort date should no longer show up as missing when it's not applicable. STS 7050, the MVR was incorrectly flagging LFU date and LFU mort stat as missing when they were not applicable based on the demographics form version. So that's been fixed. STS 7100, for version 5.21.1 records, the MVR was incorrectly flagging the race multi variable as missing, even when it was answered. So that should now be resolved. And then STS 7332, we did have reports from some sites that they were not seeing the analyzed and non-analyzed filters show up on their MVR. And so that should be resolved as well. Next slide. And then one item we did want to bring to your attention for the for January 2022 release, the GTSD participant dashboard report, that is the non-analyzed dashboard, will be updated to include the 5.21.1 data version changes. And that update will be released the weekend of January 15th. So this coming weekend. So you should be able to access the updated report starting on Monday, January 17th. And then we will work with the STS to continue enhancing the dashboard report to include additional variables for reporting visibility purposes.
Thank you so much.
Yep. Just the usual reminder that you can access a full list of known issues and enhancements in the library. And if we didn't discuss something today that you had brought to our attention via a ticket, please rest assured that we are looking into those items and we will be preparing additional items to discuss on the next webinar. That's all from me.
Yep. Thanks so much, Joe. I appreciate it. Hopefully you guys can't hear all this construction in the background, so I apologize if you can. That's all that we have here for, again, just a reminder, any analysis report questions should go directly to IQVIA tech support. You can reach out to them at GTSD tech support at IQVIA.com. And as always, STS and DCRI will be looped in as needed when tickets are escalated to tier 2. My contact information is listed here. If you need to get in touch with me for any reason, email and phone. Email is always best. If you have any database operational questions, if you have questions related to your contracts, invoicing, you have questions about the contacts listed for your site, if you have questions about direct data entry, if you could just email Jane and her team at stsdb@sts.org, and they can help get your answers to all of those questions. If you're not sure who to contact, please feel free to reach out to me directly and I can get you in touch with the appropriate staff. If you have any questions related to public reporting, please reach out to Sydney Clinton, and Sydney can be reached at sclinton@sts.org. And if Carol or Emily, if someone could just throw Sydney's email in the chat box, that'll be available to you all. Again, Sydney can answer any and all questions related to STS public reporting. Mark your calendars. Our next upcoming GTSD webinars, our next user group call is scheduled for January 26th at 2:30 Central Time, and February 23rd, 2:30 Central Time. And our next monthly webinars, our February webinar is scheduled for February 9th at 1:30 Central, and our March webinar is scheduled for March the 9th at 1:30 Central. That's all that I have from the STS perspective. Next, we'll just hop into our questions. We just have a few questions I've seen come in, so let's go ahead and tackle those. Let's see, our first question from Mindy. Any chance they will move the harvest back? We are back in staffing and I am getting behind. At this time, Mindy, there's not been a discussion from the STS or surgeon leadership regarding the current harvest close date. If there are any changes, obviously we will let you know accordingly, but at this time there's not an ongoing discussion about delaying the spring 2022 harvest close date. Our next question from Laura, looks like this one may be for you, Ruth. If we have already collected a diaphragmatic hernia during this harvest, should we go back and delete it?
I defer to Carol. I think that it's up to the individual sites.
Right.
Or so it's up to you.
Yeah, this is Carol. These are not analyzed cases, so we don't risk adjust them, I should say. So I think it's okay either way. It's how everybody should be doing the same thing, which is difficult for us to ensure that that's happening. Mm-hmm. So I guess I agree. It could be up to the site level with things with this, but we shouldn't make it we shouldn't make that a blanket statement. I think we'll provide clarification in the training manual on how sites should manage this, just to make sure the surgeons are all in agreement. So I guess refer to the training manual when it comes out.
Thank you, Carol. Thanks, Ruth.
Is that okay? Yeah, sorry.
Yeah, no, I think that's fine. Yeah, I agree. But yeah, we definitely don't want to, just give a response off the phone. We just want to ensure that we're all on the same page. But yeah, it's like you said, it won't be used in analysis. So it's nothing that will impact your analysis in a negative way. That's the most important key point there. Our next question, is there a place to collect EGD with dilation after hernia surgery, or is that completely gone?
I generally would capture that under sequence 3500 or 3560. When you do your hiatal hernia 30-day and 1-year follow-ups, there's an option for endoscopic intervention. I would think that's where most sites are capturing that information.
All right. Next question. First, I really enjoyed the polling questions. Thank you. Secondly, curious if there are any data managers on this call that are currently using the DDD, the direct data entry with IQVIA, and if so, how are they liking the program? I don't have the exact numbers off the top of my head on how many participants are using direct data entry. I see Mary's commenting that she's using direct data entry and she loves it. It's easy and fast. So there are some comments coming in that you may just want to review, but it does look like if you have more questions, Christina, about direct data entry, if you reach out to stsdb@sts.org, Jane and her team can give you, send you all the information about direct data entry, what's involved, how it works, and they can definitely let you know how many sites are currently using, thoracic sites are currently using direct data entry. I just don't have that number off the top of my head to provide to you right now. But again, just reach out to Jane and her team at STSDB. Here, stsdb@sts.org, and they can give you all of the information about direct data entry. Again, polling questions, education, very helpful. Thank you, Ruth. You did a great job. And then Christine is just saying yes, station name.
I think she wants us to add the station.
Yeah, the
name to
station name.
training manual. Yep,
Yep.
got it.
Yep.
Thank you,
And
Christine.
then,
We'll work on it.
yep, and the data collection form as needed too.
Yep.
And then there's Mary's comment about direct data entry, and then Mindy said, as she asked, thank you for answering her question. Sorry about that. Behind on follow-ups. Okay, I'm not seeing any additional questions, but while we're waiting just a second or two to see if anyone else has other questions, Carol, Ruth, Katie, Emily, is there anything that I may have missed or you guys needed to share or wanted to share with the group while we're on? Going once, going twice.
I don't have
Emily?
anything.
Emily put Sydney's email address in the chat for public reporting questions.
Great, thank you so much. Thanks, Emily, appreciate it.
Yep. And if you are looking to get CE or CEU credit for AQO, you have 3 days to do it. So it will close on January the 15th. So
Awesome.
going twice and then sold.
Excellent. Thank you, Emily.
Yeah, thanks.
All right. Okay, I'm not seeing any additional questions come in. If you think of anything after this webinar, again, please feel free to shoot me an email and I'm happy to help in any way. Let's see. Oh, Odette has a quick question. In 241, PFTs were not done during the pandemic. We were able to check unable. We're still in the PFT in the current version states the case will be excluded if missing. We haven't received any instruction. That's something we need to discuss with the task force. Carol, I know we could discuss that with Dr. Cedar, but at this time,
Yeah, I think we're gonna have to check with Dr. Cedar. I don't know that we're making that exemption for going forward with 5.21.
yeah, I don't think, yeah, we'll, Odette, we will check with the task force and we'll have more information on our next webinar, or we can, if we get a strict direct answer from Dr. Cedar, we'll put that into the training manual, we'll add that into the training manual.
Yeah, that's good.
And Emily, I wanted to know, where do we go to get CEU for AQO? Let me, I'm gonna pull over the STS website. Emily, is it on the
Yeah, I think it should be on the AQO page still.
okay.
And then I can also put the link in the chat here.
Okay. So if you go to the STS National Database, continuing education, is it, and it's here, right? The access the online evaluation core Excel. Okay. Yeah, so let me walk you through that again. So if you go on the STS website, click on the STS National Database page. If you scroll down and click on Advances in Quality and Outcomes and this will bring you to our AQO page. And if you scroll down and click on the link for continuing education, there's a link here to access the online evaluation at Core Excel. And then also, I think Emily is going to put the link in the chat. So, and Laura, I see your comment. Agree, obtaining PFTs is still an issue. So again, we'll discuss that with Dr. Cedar and get back to you all with more information about the collection of those PFTs for 521. And then Mindy, can you run reports with variables you select with the direct data entry? Joe or someone from the IQVIA team, can you speak to being able to run reports with the direct data entry option? Is that an option for them?
Oh yeah, the reports draw from the data on the case form. So whether that data gets in there via upload or whether that data gets in there with direct data entry, the reports just draw it all the same. So they work just the same way.
Oh, perfect. All right. And again, Mindy, if you are interested in direct data entry, just be sure to email Jane and her team there at STSDB, and they can give you all the information about direct data entry. Okay. All right. And again, Emily put the link to the continuing education credits in the chat box as well. All right. I'm not seeing any additional questions. I have about 10 minutes after the hour. So I guess I'll give you guys about 20 minutes back of your day. Thank you everyone for joining today. I hope today's session was helpful. Thank you, Ruth, for providing that education to us. And thank you to Melissa Clark for sharing those polling questions from the Michigan Collaborative. We appreciate it. Again, if you all have any questions, just reach out to me directly. So with that, I guess we will see you all on our next webinar, our user group call scheduled for January 26th at 2:30 Central. Thank you everybody for joining today. I greatly appreciate it. Hope you guys have a great week. Stay safe and stay well.
Thanks, Leanne. You too. Bye, everybody. Thanks, everybody.
Thanks everyone. Thanks, Mindy.